these truths to be self-evident.
That all men are created equal.
As a member of Congress, I get to have a lot of really interesting people in the office, experts on what they're talking about.
This is the podcast
for insights into the issues.
China, bioterrorism, Medicare for all, in-depth discussions.
Breaking it down into simple terms. We hold these truths.
We hold these truths.
With Dan Crenshaw.
The Eagle has landed.
Welcome back, everybody. We're going to talk about healthcare again. And by the way, if you haven't given the podcast 5 stars, please give it 5 stars. Okay. I mean, it brings other people into the magic that we create here because it boosts it. They see it. You tell your friends. It's all great. But as usual, we dive deep into topics that I'm not sure any other podcast really does, and especially with the breadth that we do with the experts that we bring on. We have a return guest today, Lanhee Chen, foremost expert on healthcare. He's in the public eye on this issue a lot. And we're going to have this conversation in a way that I think makes sense to people. And refute some of the sloganeering I think you often hear on the left, especially things like healthcare is a basic human right. Now, that sounds good, and I would certainly agree that people deserve to have access to healthcare. But to say it's a human right is perhaps an overstep. And it would raise a serious question: if healthcare is a right, would a doctor be obligated under law to give their time? To get paid whatever the government tells them they will get paid to service somebody else. I mean, can you do that? If the doctor doesn't do it, can they go to jail? This is what you're talking about when you talk about an inalienable right. Now, that doesn't mean that we shouldn't have options for healthcare and better options than we have now. And so we're going to take a look at Medicare for all, Obamacare, price controls for pharmaceuticals, and other healthcare entitlements for seniors. Every one of these policies puts the federal government in the driver's seat for virtually every aspect of our healthcare system. These policies have consequences for our economy, for the type of medicine and therapies we have access to, and for the overall delivery of our healthcare. So whenever we try to change these programs or improve them, or at least put them on some kind of, financially stable trajectory, Democrats say we're trying to strip away a basic human right. They fear monger. We just take it on the chin and we back off. We don't talk about healthcare policy enough. And that's why I bring it up, I think, a lot on this podcast and with experts like Dr. Lanhee Chen. So, hey, thanks for being on.
Hey, great to be with you again. Thank you.
Want to talk about affirmative action? Because
it's timely, right?
Yeah, it is. I mean, when people will hear this podcast, I'm not even sure when we'll release it, but just so everyone knows, this was the day that the Supreme Court overturned affirmative action. And you're at Hoover now. You're at Stanford now. What do you guys? I mean, you must be talking about this a lot.
Yeah, I mean, it's first of all, I think it's a massive decision because it reaffirms the belief that I have, and I'm sure many of your listeners have as well, that when you look at America, what we try to do is we try to assess people for who they are, not for the color of their skin, not for, how they show up, not for how they're dressed, not for any other elements of who they are aside from their entire person. And what the court said today essentially is, look, when you admit people to colleges, you got to make sure you're doing that, right? You got to make sure you're looking at the whole person and not just making a decision through the lens of race. And it's a long time coming. By the way, this shouldn't be considered. I've heard some commentators on the left say, oh, this is precedent breaking. It's so crazy. About 25 years ago, in the last Supreme Court decision the court had, Justice O'Connor, who wrote for the majority, said, hey, listen, in 25 years, this probably won't be needed. And guess what? We're about 25 years down the road right now. So the notion that this is like some crazy...
They had no argument. And they had no argument
no, because
when would the right time be? And that's a key
when
question.
Is enough?
Yeah.
When is enough? And the court said that. Mm-hmm. The court said that today, right? They're like, hey, when is ever going to be enough? Right. And so anyway, this massive decision in my view, and the court, it came out exactly the right way.
I did a Harvard Crimson newspaper. A student interviewed me on this yesterday, and it was such an interesting kind of back and forth. I don't know if it was a back and forth. I don't think she was debating me necessarily, just asking questions, just to be fair. But I thought the questions were really interesting, and because they were always framed a certain way. And
right,
one of the questions was, well, don't you think background should matter when assessing admission to a university? And I said, yeah, of course.
Absolutely.
But you said it, not me. You said background. That's a really different, it's very different than saying an immutable characteristic such as skin color. Those aren't the same things. when she said that, I was like, I immediately caught on to it. And then, but it brought this whole issue to light for me, in a way that I hadn't really looked at it before, which was, I realize now how badly they've conflated those two words, background and race, as if they are indeed the same thing. And I'm like, you can't say those are the same thing. You can't. You can say in the aggregate, there are averages, there's a probability that because someone is this skin color, they might be less, whatever, on average. But when it comes to admission into a university, you obviously can't say that. And I'm like, look at background. Look, if there's nothing in discrimination law, and there's nothing against our basic foundational principles that say, look, we want to have a more diverse student body from all 50 states. I don't think that would be grounds for discrimination. If you're like, you know what, I want more people from rural Alabama. I don't have anybody in my university from rural Alabama. That is a very clear background difference that might bring some kind of perspective to my university. But you can't definitively say that based off of race alone, which is what affirmative action is. This is what I explained in that interview. I mean, like, there's no good arguments for it. There just isn't. Because if you're worried about socioeconomic background, then do a socioeconomic indicator. I mean, do that.
Yeah, no, and I mean, to your point, you can look at someone, and by the way, the Supreme Court left the door open for this today. They said, listen, you want to write it. A lot of these colleges require you to write an essay. Okay, you want to write an essay that talks about your life story and how all these different factors have influenced your life. Go at it, great, right? And I'm for that too. If you want to tell your life story, and a part of that is who you are. And a piece of that is, listen, I grew up in this part of the country. I grew up with this kind of a composition of my family, et cetera. That's totally fine, right? But the basic point is, do you want to allow race to be a controlling or predominating factor in the way that it has been in too many situations? And the court today said definitively that's not the American way, and it's not constitutional, by the way. So. Like I said, I think a lot of people will look at this and they'll pick it apart, and there'll be a lot of litigation, right? We're a really litigious country, so we're going to see a lot of lawsuits and stuff. But at the end of the day, the basic principle that we stand for, which is that we look at people as people, not as characteristics. That's something I think we all ought to be in favor of.
It's amazing that, honestly, affirmative action has withstood the challenge of the 14th Amendment for this long. Like, I mean, 14th Amendment declares that you have to apply the law equally to all. I mean, that's a pretty strong statement. It's deeply embedded in our founding. The Declaration of Independence, it's a revolutionary document, that it declares all men are created equal, and subject to the same laws, subject to the same forms of justice. The other interesting counter argument I got was, well, but those same laws weren't applied. Those laws were applied unequally before, and so doesn't there have to be justice for that? And I said, of course, but you can't have 6 degrees of separation from the injustice to the justice, where you now have people who weren't involved at all in the injustice. Like, imagine if that's how the world worked. It would be crazy. And that's basically how race politics works within the left. It's this system of justice that is 6 degrees removed from the injustice itself. And that's a monumental.
Well, and the other problem this came out in the course of this litigation that led to the decision today was, there were injustices being perpetrated on others. Right. And so, for example, you look at the direct discrimination that happened against Asian American applicants as a result of this. And by the way, you look at the statistics on admissions and applications to Harvard as an example. Yeah. And we don't find it at all suspicious that the band of percentage of admitted African American students and Hispanics remained exactly the same over, like it was some accident or a fate. Yeah. No, I mean, obviously there was some social engineering going on here. And the fact of the matter is that the court ultimately concluded there's no endpoint. The advocates have not articulated when is enough. And in any policy, if you're going to have such a significant view that that is contrarian to what the Constitution says, you better have a really good excuse for it. That's what the court has always held the standard has been. If you're going to use race as a factor, you better have a incredibly compelling interest. And today the court said the interest just isn't there anymore. And like I said, I think we're on the same page on this one, which is that we ought to look at people as people, and let's start there.
Yeah, no, it was really interesting. This court has done so many monumental things.
Oh, it's incredible.
Over the last couple of years.
Absolutely.
It really is. All right, let's talk healthcare. I don't know if they're going to do anything on healthcare anytime soon, but hey, we'll see. We'll see what we throw up there.
Let's hope not.
So there's a new insolvency date for Medicare. Medicare is one of our biggest spending programs. It's worth noting, and I'll continue to note that during our big debt ceiling fight, we're actually fighting over 11% of all spending because we took Medicare off the table. We took Social Security off the table. We took
Great point.
Yeah, we kind of took Medicaid off the table. We were asking for work requirements there, but we took military spending off the table. We took veterans benefits off the table, veterans affairs off the table. So that left 11% of total spending. If you care about spending, that's why I kind of got, that's why I say to the people who voted against, the Republicans who voted against it on the grounds that it was a terrible spending bill. I'm like, well, then you have to tweet the next day. You have to tweet, be honest, that what you really want to do is cut Medicare and Social Security. Say that, because that's that. If you're a true budget hawk, that's what you'd say, because that's what's actually driving the debt. It's what's actually driving our spending, and we do need to reform it. I mean, I openly say it, so like I'm okay with both. But now it's 2031. I guess they could push back. I guess there's some good news there, but the bad news is I'm pretty sure that's because of COVID. And we think we lost a bunch of elderly people. I think that's why it got pushed back. So there's no good news there, I suppose. But every time we talk about Medicare, Social Security, President Biden says we want to cut Medicare. We want to cut our benefits for seniors. He's lying. We don't have any actual proposals to cut Medicare, but also not doing anything to fix it is the same as cutting it. So what do you think? I mean, let's talk broadly. What is the best path forward on Medicare? Solve it for me in a 2-minute answer. I don't know.
Well, I wish I
go
could,
longer than 2 minutes.
No, I mean, you're making exactly the right point, which is that if we don't do anything about this, we are going to see cuts, and that's how we're really going to see cuts, right? All this political garbage that we're hearing from the administration and from the president and from folks on the left, it's just scare tactics. Because at the end of the day, here's what's going to happen. If Medicare does not get its fiscal house in order, the law requires that physicians see their compensation cut. Now, if that happens, what happens next. Patients don't get seen. People don't get treated. So this idea that reforming the program now is cutting it is asinine. Reforming the program now is what you need to do to avoid the cuts.
Save it.
And in actuality, what we've seen over the last couple of years is that when you apply principles that apply in every other part of the economy, competitive marketplace, giving individuals choice, giving seniors options, giving them more benefits to use in a program called Medicare Advantage, what we've actually seen is that works. That works. What's not working is top-down federal government control. And the idea of extending that increasingly, which unfortunately many of our friends on the left want to do, they want to take the model of more federal control and apply it not just to people over 65, but to everybody, right? Medicare for all, something called the public option, which is almost as pernicious. All of these different things, all they do is limit choice, drive up costs, and make them fiscally unsustainable. So we do have to address Medicare. And look, we should have a debate about how we do that. And I understand there may be people within the Republican Party who disagree on how to do that. That's totally fine. But we need to have that conversation now about how do we address these challenges? Because if we don't, you raise exactly the right point. We are going to have cuts. And those cuts will come, whether it's 2031, 2032, whatever, the date will bounce around. But we know that in the next 8 to 10 years, there will be a fiscal reckoning if we don't solve the problem now. And the example I give is like when you put money in your bank account, the great thing about it is this concept called compounding interest, right? You build on your money, the money grows faster. The opposite's also true, which is if you don't solve a problem now, it gets worse and it gets harder. Yeah. And that's what's going to happen with Medicare.
Yeah. And when we say they get cut, that's by law. I mean,
by law,
when the program goes solvent, according to the law, there's nowhere to get the money, so you have to make cuts. I mean, it's in the law.
That's right.
So yeah, anybody who refuses, it makes me mad about our current primary election too on the Republican side, because I'm not endorsing one way or the other, but I don't like the disingenuous attacks about Medicare and Social Security that are basically repeating Democrat talking points. It's just false. They're just false attacks. I mean, so Medicare Advantage, is that the model for how Republicans should think about healthcare in general? And I guess I would describe that model as, look, it's a mix of like a government safety net with but that is applied to the free market. Not to simplify it, it's not that different from like a voucher system with food stamps or housing vouchers. We give you money, you go on the open market, where people compete with each other and they're competing for your dollars. It's not a perfect system. It causes issues, of course. I mean, we see it all over it. Student loans are kind of the same thing, but it's better than a government bureaucracy. Now, Democrats love government bureaucracies. I don't know why. They would never want to like run one. I mean, some of them do, but they don't run it well. Yeah, they don't run it well. And like once you're there, you're like, God, it just by its very definition, it doesn't have an incentive to do better. Like, and you'll never change that. You'll never change human nature with a bureaucracy. If you're not incentivized for profit, and like it's the same in the private sector, if you don't incentivize your employees properly, they're just not going to perform. They're going to come in 9 to 5 and they will be gone by 5 o'clock. They have no good reason to stay that you're incentivizing them for. But the bureaucrats never have a reason to stay. Never. Like, so it's just always going to run more inefficiently. But is that how we should think about healthcare in general, or is that a simplified?
Yeah. No, I think you raise a lot of good points there. So what I like to start with in the healthcare conversation, like where we really have challenges right now, in my view, is that if you look at any other thing you buy, you have a lot of information about it usually, right? Kind of the quality and the price, and you can go online. I don't care if it's a car or a TV or whatever you might be buying, clothes. You can be an educated consumer. And in healthcare, you can't be. Right. Yeah. We have all of these crazy things in the system that make it very hard for you to figure out exactly how much things cost. What am I paying for? What's the quality of things I'm getting?
That's true.
So we got to start with transparency in my view. That's the first place we have to go to. And we have to be able to create
some kind of simplicity.
Market.
Yeah.
Sure.
Sorry. Good.
No, I was going to say we're going to probably get to this in the conversation, but increasingly we're seeing these things pop up called direct primary care, and the concept with that is simply, hey, I'm going to have a agreement with a doctor, and that agreement is going to be directly with the doctor, and they're going to see me when I'm sick or when I need something, and we're going to have that arrangement. Now, the reason why those arrangements are taking off is because they offer a level of simplicity and transparency that the current healthcare system doesn't. So what happens now is you go and you get a healthcare service and you might pay what we call a copay. You show up at the doctor's office. Here's $15, $20. I'm gonna see the doctor. Then you get this bill afterwards, and no one knows what this bill means, right? Like you get like, what does this mean? What are all these codes on here? Why?
Right.
We don't have a level of simplicity and transparency in our system. Imagine if we had a system where we knew exactly what it would cost to get certain things, and then we could go and figure out quality-wise in a very similar way to how we buy other products. We had a sense of what is the quality of this provider compared to another, this hospital compared to another. If we had full and visible transparency, you know what that would do? That'd drive down cost. That'd make healthcare cheaper. So when I hear people talk about, healthcare costs are going up, it's like, yeah, they're going up because we don't actually know what we're paying for. So let's start with the basic problem, which is we need more transparency. We need a better understanding of how these services are being provided.
So we're obviously in the process of enforcing that transparency. This is one of those rare bipartisan issues. Actually, Democrats are fully on board with a lot of changes. The hospitals don't like them, but we knew they wouldn't. We're sorry. So the transparency part. So what we mean by transparency is forcing hospitals to list their prices. Now that doesn't do anything for the education problem that you talked about. Like I think I know healthcare policy okay, and I would still have a lot of trouble navigating this system, like as a patient. That's why I just go to the VA.
Well, and that has its own issues, by the way. But
but not for everything, of course. We have a good VA in Houston. Anyway, we could get into a whole VA discussion. But it's important to note. People are like, "Oh, see, Dan, you just admitted it. You want a government bureaucracy to do your healthcare." Here's the thing: the VA can't exist without the private sector. It can't. It's impossible. And you have to recognize that if you expanded the VA to cover everyone, it would be impossible. The Houston VA is one of the best because it's got this great education system rotating with Baylor, and like Houston's just a hub of innovation anyway. So there's a lot of reasons it works, but it's not because it's a government bureaucracy. It works despite that, and it works off the back of the private sector in a very fundamental ways. So just worth noting that. What was I even talking about?
We're just talking about the fact that it's hard to navigate even as an expert.
To navigate it. And so my question is, is there a way, is there something government should do in that respect, like a rating system, or like, like this is the Yelp site? Because it's not obvious that the private sector takes that on. Companies will try, but like, again, the consumer's like, okay, well, which one do I go to? Which Yelp site do I go to?
Yeah. Is it Angie's List? Is whatever. Yeah, no. This is where I do think there's a role for government to play. Listen, I'm not one of these guys who thinks, the government never playing a role. There is a role to play here. And we actually have it a little bit in terms of comparing hospitals. The Center for Medicare and Medicaid Services has a service they call Hospital Compare, where you can go online, you can take a look and see what the general quality is of hospitals, in a sense, on specific procedures, right? How they do on knee replacement, how they do on cardiac surgery, et cetera. So that's good, but we need more than that, right? We need to understand at some level how well are physicians and providers providing service. We need to make sure we have that information readily available. And some private sector companies, for example, try to make that available information to their employees. Or, there's a famous story, for example, of how Walmart has what they call centers of excellence, and they know, hey, here's the guy you got to go to if you need a knee replacement. Right. And they would rather take an employee and fly them to see that doctor and put the family up and do all the rest, as opposed to having them see their local provider. Mm-hmm. But unless that kind of transparency is enforced across the economy, and we have a greater level of understanding and a common language to speak around this, it's going to be hard. So I actually do think there is some role, whether it's in legislation or from a regulatory perspective, for government to step in and say, we're going to provide this,
Yeah, you got to have a one-stop shop, and that's the most important thing. It's too damn complicated. Yeah, you talked about direct primary care, so might as well get into that a little bit. Obviously, this is an issue I talk about a lot on the podcast. I'm pushing this issue across multiple committees in Congress right now. It's an easier arrangement, right? You pay a fixed fee to a primary care doctor, and you have access to that doctor. Yep. Now, it's not insurance. It's not for a knee replacement. But we're talking, right, 75, maybe $80 a month. And ideally there's an app, and actually there is a website. You can go and find this exact comparison, kind of shop around that we're talking about. Type in your zip code, find a direct primary care physician, compare their pricing. And that pricing should be different. Maybe one is more qualified, more experienced than the other. Maybe one offers lab work and the others don't, but it should be transparent and pretty much easy to understand. And I think it's so important to start there, because as a patient, you start your entry into a healthcare system, unfortunately, because something's wrong with you, but you always start that with a primary care doctor. That's where you start. And so I think that's where our policy should start too. And then we can build from there, because ideally you have that primary care physician, and then that primary care physician helps you navigate the utterly horribly complicated insurance environment that's out there. Maybe that's our next question for you. So Affordable Care Act, one, I guess I have a lot of questions about the Affordable Care Act, but there's a 2025 date coming up when the subsidies expire. So the subsidy system covers the cost of the private plans that kind of prop up this entire law. What should we be thinking about as policymakers? Let them expire, make them less problematic.
Yeah.
What's been the problem with these subsidies? What have they done to the insurance market?
Well, when the Affordable Care Act first passed, one of the things that I wrote about a lot was what the impact would be on costs, and we've seen it. Right, we've seen insurance costs increase, and some of that is because if you subsidize something, you're going to see costs go up, right? Because that's a natural thing you see in the economy. So. And these subsidies have been expanded massively, to your point, as part of the Inflation Reduction Act and a couple of things that were signed into law recently. The subsidies got extended to the point where you've got people making hundreds of thousands of dollars a year qualifying for government subsidies to buy health insurance, which is ever more expensive and doesn't meet their needs. So we kind of need to figure out, in my view, that stream of money. What's the best use of that? Is it subsidizing insurance companies or actually giving people help if they need it? And I'm in the camp of, if you want to help people, help them directly. All right. Don't go through the middleman. Don't make this so difficult. And so in my view, there's a couple things we need to be doing. First of all, we talked about the transparency piece. I think that's key. Second of all, I think we need to figure out how we can fix these markets. And that happens, in my view, at the state level. State by state, we should be giving states flexibility and freedom to have insurance products and markets that work for their residents, because what happens in Texas is really different than what we've got here in California. You go to a state that's predominantly rural, they're going to have different concerns. Why do we have a one size fits all system? And why do we have one size fits all subsidies? That never made a lot of sense to me. So we need to be incentivizing, in my view, states to do more. We've got to fix the tax code, because one of the things we've got at the federal level is a tax code that incentivizes the purchase of ever more insurance. In other words, I actually do better financially if I buy more expensive insurance. That's a totally kind of wrong-headed incentive structure, in my view. We have to make it so that what we're incentivizing people to do is to buy insurance that works for them at a more limited price point, if that's the case. So the example I give, one of the things the ACA did is it said everyone's basically got to have the same kind of insurance. All right. I don't care if you're 22-year-old male or a 70-year-old woman, you got to have the same kind of insurance. We all know that doesn't work, right? Because a 22-year-old person probably thinks they're never going to get injured, probably thinks they'll never need healthcare. They go snowboarding all the time, whatever, right? Their needs are going to be very different. So why don't we have an insurance system that meets the needs of people where they are? If we do that, that's actually going to help us reduce the cost of health insurance, expanding choices. In a couple of weeks, we're going to have a plan coming out of the Hoover Institution, some colleagues of mine and I, that outlines what we think the next generation of healthcare reform looks like. We're calling it the Choices for All plan. You know, the left talks about Medicare for all. I'm about choices for all. I actually think every American should have a choice of the kind of health insurance that suits them best. Yeah. And we propose a series of policy changes that are going to get us there. And I've talked about a few of them here already, but the fundamental point is this: one size fits all doesn't work. Yeah. One size fits all subsidy structure. And you know, the subsidies, there's going to be political pressure to extend them. The reality is, the better question in my mind is, how do we use that money to actually fix the problem of people having sustainable access to health insurance? Because if you keep subsidizing, it's just going to get more expensive, and we're going to spend more and more money, and we're never going to solve the problem.
Well, I mean, it goes back to, again, the original sort of philosophic underpinning behind healthcare. Okay, how should we do it? Who should we subsidize? You're going to subsidize somebody, because there is a common belief. When I addressed the whole human right thing at the beginning, but we are in the end sort of saying the same thing. We want Americans to have access to healthcare. So let's just agree. We agree on that, and it's, you know, a doctor is, if somebody shows up at the emergency room, you do have to treat them. Like, so, and it's, we already acknowledge this. And I think Republicans, you know, we have to push back against the talk of human rights, but we have to also accept that we also want it as a service, at least, or as an option. And so I like choice for all. I've been searching. I think we have a pretty common kind of philosophical framework for looking at healthcare, and I've been and I think about how to market that all the time. And we've been searching for a name. So if the Hoover Institute is coming out with something good, I look forward to that. And
you know, the reality here is, the other thing I would say is, we can be for everyone having access to health insurance. And you know, I think one of the areas where maybe we've lost some moral high ground as conservatives is there's a sense that we're not for everyone having health insurance. And nothing could be further from the truth, by the way.
We're for access.
We're for access. We're for making sure everyone has access to healthcare. Yeah. Absolutely. And affordable access. I get that.
Maybe access for all, choice and access for all, just like really drive it home.
Yeah.
But we'll work on the marketing as we go forward, but I like it. But the question I wanted to ask about again, fixing that market, some have said that instead of subsidies, there should be a reinsurance. There should be reinsurance. What do you think about that? So reinsurance is basically insurance on the insurance. Once the bills hit this huge amount, the insurance company is no longer liable for it. They would rely on maybe a government-backed reinsurance program, which keeps overall premiums down, because the insurance companies know that their costs will never go above this whatever $1 million threshold or whatever it is.
Yeah. So the elegance of that concept is this, which is that we know what makes health insurance expensive is when people actually use it and consume healthcare services. And it's also the case that actually that consumption happens amongst a relatively small percentage of the population. So if we could figure out a way to really take those costs, do what we need to isolate them in some ways, then what does that mean? That means the rest of the market gets cheaper for everybody else. That's the basic idea behind reinsurance, is we want to take that part of the market we know is more expensive, and we want to figure out how we pay for that.
Right.
State of Alaska, a couple of other states, remember I said earlier, we ought to have a state-by-state approach. A couple of states are doing this now, and they're actually taking the subsidy money that we talked about earlier, and they're applying it to create a reinsurance system so that we are really subsidizing high need, low income people who are consuming a lot of healthcare. And the benefit to that, of course, is that everyone else's healthcare gets cheaper. So reinsurance is definitely part of the solution here. It is definitely, but the basic concept, I just want your listeners to understand that what we're trying to do is we're trying to figure out, how do we really target the money? How do we really target the money we're spending and getting a high return on that investment? Because the problem now is, and this has been the general problem in my view with what the Biden administration has done the last couple of years, they're just spraying money around, right? It's like, oh, I don't know if it works or not, but let's just throw money at it. It doesn't work in healthcare. That just doesn't work in healthcare. You have to be targeted, and you got to figure out who really needs the help and how do we get it to them. And so reinsurance is one of the ways we do that.
Yeah, and well, how does that compare to a risk pool? Which ones? Which in your research,
similar
which
concept
one works better?
Similar concept. The idea of creating a high risk pool and subsidizing the high risk pool is basically saying, we're kind of saying the same thing, but in two different ways. Reinsurance just basically means that we have a top point at which insurance is responsible, and then the government kicks in. The high risk pool is a little different in the sense that we're saying we're going to take a group of people who we know are high risk, we're going to put them in a different pool, and we're going to subsidize that pool.
That seems more
we get to the same place. A little bit, because we actually tried it right after the ACA, and it ended up being really hard on cost containment, and it wasn't successful in many cases. So the concept of reinsurance has become more popular, because there's actually a robust private market for reinsurance now. Many companies are offering it. And then the other issue that we have there is that we just, we have less experience around it. So it's probably good to begin to try something that we know could work, as opposed to something we know probably didn't work. So reinsurance as a concept makes a lot of sense to me. We got to do it in the right way. And again, we can't have Washington telling everyone to do reinsurance, right? It'll work in some cases. It'll work in some states and some markets, but not everywhere. And so we need to allow that flexibility and freedom to exist.
Yeah, that makes a lot of sense. On Medicaid, we did try to touch this in the debt ceiling negotiation, but only via the work requirements, because it's a form of welfare, so it's kind of attributable to that. But certainly not in the benefits area. It's one of our fastest growing. I had a number here a second ago. Where was it? I mean, it's an extremely one of the fastest growing programs in federal government. Again, like I said before, one of the big parts of our spending and entitlement program. How should we think about Medicaid? What are we doing wrong? Are some states doing it the best way possible? What do you think?
Yeah, this is a hard one. Medicaid spending has increased exponentially since the Affordable Care Act was passed. In fact, 80% of the coverage gains in the ACA, 80% came from Medicaid expansion.
Yeah.
It's a blunt force instrument. It's just something that people just said, hey, we got to get people on insurance. And we didn't ask the right question. The question is not, do they have insurance? It's, do they have access?
Yeah.
And the problem with Medicaid is that in many cases, we're seeing longer wait times. People can't get access to a physician because physicians can't like magically see 40% more patients. They just, that time, there's only so many hours in a day, right? So when we expanded the Medicaid rules, we gave people insurance, but we didn't give them a way to use it. We weren't smart about how to do that. So the challenge we have with Medicaid now is a couple things. One is the program expanded tremendously. Second, it's fiscally unsustainable for many states because it's a state-federal partnership. A lot of state, the states got to kick in some money too, and a lot of states are saying we don't have any more money. We can't do this. And then now we have this issue where what is required under the law now is states have to go and make sure that people on Medicaid are supposed to be on Medicaid. It's a process called redetermination, and it's part of the fraud prevention system that we have in place. And I was talking to a colleague of mine who does a lot of research in this space, and he was saying that they're seeing in some states 25 to 30% of the people who are on the rolls right now actually have other insurance. They have employers paying for insurance, and they're on Medicaid. So people are covering, taxpayers are covering them, and they're getting covered by someone else. That's wrong. If they're getting coverage from somewhere else, they shouldn't be on Medicaid. So this process of redetermination is actually a very important thing that we're going through now. So we're going to get the roles to where they should be. And then going forward, we got to figure out how do we make Medicaid work better? And I think the answer there again is let's continue to infuse more choice and competition. And then let's give people on Medicaid the ability to save for their own healthcare expenses. We shouldn't assume because someone's on Medicaid, they function differently. The same concepts that we apply to people not on Medicaid should be applied to people on Medicaid. We should be giving people a hand up, not just a handout and say, hey, you're on your own. We should be helping them understand, how do you save for your own healthcare expenses? How can we help you do that?
Yeah.
And that will make them more conscious of the services they're using as well, just like everybody else in the economy. So Medicaid needs to be fixed and the trajectory needs to change. Unfortunately, a lot of that's political. That's in the realm of what kind of fights are you going to have about who's taking away healthcare from whom. And it's just not a productive conversation in the political arena, unfortunately, because what we need to be doing is fixing the program, not having a political fight about it.
Well, every entitlement ends in that discussion. You want to change it, you want to take it away, you want to take something away. It's like, well, you didn't really have it in the first place, but okay. And like your point about 40% more patients for doctors is exactly a better way of making the point I was making at the beginning of the podcast, which is, look, we want doctors to see patients, but I can't force you, a doctor, to stay up 24 hours a day to see patients just because I've decided that you'll see. I mean, you just can't. Like again, it goes back to actually our earlier discussion on affirmative action. One, to right an injustice, you can't place an injustice on someone else who had nothing to do with the injustice in the first place. Which is what affirmative action is, and it's what philosophically it's what a lot of these crazy policies that I think are just inch deep reasoning by kind of feel good liberals. They end up in this backwards position where you're actually creating more injustices than you had in the first place. The other what was I going to ask about Medicaid? What do you think? I can't really explain in proper terms how Texas does. I'm not asking you to be an expert on Texas's Medicaid program, but we're a non-expansion state. We rely greatly on sort of our public hospitals and funding those as sort of these repositories for the underserved. We like that model. We get our 1113 waiver in order to innovate throughout that model. Is that a good model in your opinion? I don't know I'm not sure how much you've looked at Texas, but what do you think?
So the basic premise is states should be able to do what serves their citizens best. So if Texas makes that decision, that's Texas's decision. Other states have decided differently. I would say I like the concept of having a robust network where people can get care in a way that makes sense. And what I mean by that is that the other day, my son, who's 12, he was playing basketball and he fell and he cut his chin open, right? And there's a couple of ways you deal with that. One is you go to the ER. The other is you go to a urgent care clinic and you get it seen by a nurse. And one is a lot cheaper than the other. And the outcome is probably the same, right?
Yeah.
So we need to be making sure that people are seeking care appropriately at the appropriate place, which is why, by the way, this direct primary care thing applies in this context as well. Because what you can do is, instead of saying, hey, we're going to subsidize institutions, let's subsidize people and let's help them get a direct primary care arrangement so they can go and see a primary care doc, so they can diagnose cancer early, so they can make sure that flu doesn't become bronchitis that lingers and ends up causing bacterial infection. That means they got to end up in the hospital. We want people to be getting care early, and we want them to be staying on top of their health. And the current system we have, whether it's Medicaid or subsidizing healthcare institutions, I don't think that exactly gets it right. What would be right is for every person to be able to have access to that primary care person who can make that diagnosis and get them to where they need to go. And then we can have a conversation about, okay, if they need more care, what's the right venue and how do we subsidize that if they can't afford it? Some of that's going to come through Medicaid, but some of that will come through your point. If we're subsidizing institutions, and by the way, let's not forget, we've got a very generous people in this country. And there's a robust nonprofit sector. There's religious and faith-based organizations that are stepping into the breach as well. We need to be combining all of these factors and resources to make healthcare more affordable. But what we can't have, and in fact, it's illegal to have, is the federal government telling states, you got to do it this way. And that I think is something that, Texas is going one way, and people can discuss and debate whether that's the right direction. California, where I live, has gone a very different way. California has basically said, hey, we're going to pay not just for healthcare, we're going to pay for housing and transportation. And again, the wisdom of all that is up for debate. But the basic point I would make is, are people getting access to the care they need when they need it? And that's why I love these arrangements that are about direct to consumer. Let's go around the middleman. Let's not worry about the middleman anymore. Let's figure out how we get people what they need.
It'd be nice. And I think Republicans, as we unveil our plans, or at least visions, vision might be a better word. It's a word I like to use, because with a vision, I'm creating an ideal reality. Okay. And I'm admitting that it could take 20, 30 years to get there, but at least where I'm trying to go.
Yeah.
And, and part of that reality is, look, just like you got a social security number, if you're a taxpayer, to forget it, not even social security number, but just a taxpayer, you should have access to a health savings account, and everybody has that debit card, or maybe it's a credit card. I don't know. It doesn't matter. It's your card. And if we deem you eligible for some kind of subsidy because of your socioeconomic status, that money goes into that account, or you can save money to that account, right? Which gets to your earlier point about, buying into your own healthcare. That would be it would be such an easier reality for people. And then when you want to shop around, you have that one-stop shop, that website you go to, that app you turn on, you pick your doctor. You're not worried so much about I don't know how we solve that problem, the insurance networks problem, whether that's something we need to change or who knows. But in any case, you start to add all of these lines of effort together with transparency, education, one-stop shop, financing through a tax deductible health savings account, direct primary care. And you do start to build a vision that I think a lot of people would really like.
Yeah. Again, the linchpins of that are, we're helping people. We're not helping others, right? Or others who are in the system.
Yeah.
We're giving them choice. We're giving them choice. We're giving them access, and then we're giving them the tools they need to make educated decisions, and that should be the future that we're headed toward. And I love your concept of a vision, because we need a vision on this, because we get bogged down in the details, and the reality is, for most people, they just want things to work. They want it. They want to get access to the healthcare that they need. They want it to be affordable, and they want to get good quality care. And we need to be focused on that North Star. And what do we do to get people there? Because right now the system is not serving a lot of people. I mean, there's tens of millions of Americans who are not being served by the system well right now. And that part we can fix. That part we can make better. And, yes, we're going to have to face the political charges from those who believe we're trying to upend the current system. And, my point is, the system ain't working for a lot of people. Yeah. And if it's not working for them, we ought to fix it.
Yeah. What do you like so much about the current system? And I encourage you guys, when you roll out your choice for all, I've been meaning to do this, but my bandwidth is more constrained than maybe a Hoover institution's bandwidth might be. But you need a video. You need a 5-minute video, less than that, a 2-minute video of, whatever, Sally in the year 2035. In the year 2035, this is Sally's experience with healthcare. That's what choice for all means, right? I mean, and then you go through exactly what I just said. Look, you go on an app, and in 2035, the app will be like, a hologram in front of your phone. It'll be so cool. And then, you move it around with.
I shudder to think about the future. Yeah.
Or it'll be hell. I don't know. It's going to be one of the two. It's either going to be the Jetsons or it's going to be hell. We're not right, or maybe somewhere in between. But like you play out that story, you show like the account, the debit card, and it's like, what? That's the vision. Like you just laid it out. So maybe that's my recommendation. Because I love it. I don't have time to direct another movie.
No, we'll do it. We'll do it, and then show it to you to get your feedback.
Yeah, we'd love to work with you on it. Lanhee, thanks so much for being on again.
Always great to be with you.
I think it's your second time on the podcast, right? I really appreciate it.
Yeah. No, I love it. Thank you.